Hello, welcome back. You're listening to episode 80 of Total Knee Tips and Pearls. I'm your host, Adam Rosen. So, in this episode, I want to just kind of welcome in the new PGYs. I want to try something today just to try to get you off on the right foot because, if you're a new PGY1, you're getting thrown up in front of the x-rays at X-ray Conference. And what I've seen over the years is sort of a change in, I don't know if it's the education in medical school or, on the rotations, but there's the ease now of sending a picture, right? So someone says, what's the x-ray look like? What's the fracture look like? And it's very simple to snap a picture and text it to them. And what I've seen is people have lost the ability to verbalize what the x-rays show. So even though everybody's sitting in front of the screen, or you can send them the picture, it still is good to get into the habit of being able to use words to describe the x-rays. And it also helps paint a picture, and it helps, in a lot of instances, if you then know the classifications, helps dictate the treatment or the potential risks of failure of certain treatments and things like that. So I do think it's really, really important to understand that. And I think I'll put this on the to-do list to do this in a YouTube format. It may be good to go over some x-rays and go over them that way. Because I just finished a YouTube video for patients which went over x-rays, specifically knee arthritis, just to show them the continuum of this is a normal knee. This is mildly arthritic, moderately arthritic, severely arthritic, varus, valgus. Those are the different things, because you can explain to someone they have arthritis, but if you don't have a series of other x-rays to compare it to, it doesn't always make a lot of sense to them. So without further ado, when you get up there, and there's an importance to this, and I'm going to talk obviously mainly about, knee arthritis. We'll throw in some hip arthritis, and I'll throw in some little tips and pearls on fractures. I mean, I could probably make an episode on, every joint and the fractures and things, but a lot of the tenets hold true. So when you get up to talk, for starters, describe the views. And again, if you don't think of these as this, BS thing that you have to go through these steps, but also when we are dictating a note, whether or not you have a private office and you're actually billing for the reading of the x-ray, or you're putting it into your note, or maybe you're submitting for authorization for surgery, having all of this information in there is important. So don't think of it just as this like verbal sort of minutia that you're going through just for fracture conference, but you're going to use these same words when you document and dictate a progress note, a consult form, a preoperative history and physical. So, for starters, describe the view. So for knee x-rays, I'm seeing patients over 50. We typically get 4 views, and I'll describe it as we have a weight-bearing AP, a Rosenberg, a lateral, and a merchant view, or maybe you prefer to get a sunrise view. But you describe, okay, these are the views that we have. Well, why is that important? Well, first of all, I'm looking and making sure, are these weight-bearing x-rays? Because a AP supine view is not as important, and it explains a different picture. So it also makes sure that you capture that information. And again, one view is no view. So you need at least an AP and a lateral, but you can even comment, on, AP and an attempted lateral, so it gave you more of an oblique. So your ability to comment on what you see may be limited because you've described that x-ray is suboptimal. In a perfect setting, the tech would have realized it and reshot it, or the tech would have sent it to the radiologist, who would have said that's inadequate, go back and reshoot it. In the reality, they're going to wind up in your office with a suboptimal x-ray more often than you'd like. So you want to make sure that those are the things. Now, if you're looking at, a hip, same thing. You might say, I have a weight-bearing AP of the pelvis. Might say it's more of an inlet view or an outlet view. Well, again, cues you into some other issue. Was that the view, or is that some pelvic change due to some lumbosacral issue? And then I might have an AP and lateral of the hip. Well, is the lateral a frog leg? Is the lateral a cross table? So I'm being very specific, but it's letting you know. I mean, if you're looking at a pelvis, or you're looking at Judet views, if you're looking at a shoulder, did you get an axillary? Did you get a Velpu? Did you get a, scapular Y? Or was it just the X-ray urgent care AP internal external rotation view? So all of those things are important. Weight-bearing joints, the foot, if you're looking at a Liz Frank, the ankle, if you're looking for a syndesmotic disruption or ankle stability or ankle arthritis, got to be weight bearing. Even an ankle injury, does it include a tib fib? Can you see the proximal fibula? So all of these things are things that you're speaking to the audience or your upper level residents or your attendings, but it's also making your brain think, what are these things that I have to be thinking about and looking at? Now, again, the next thing for my world isn't really a big deal because I see patients that are older, but always it was a good habit in the beginning if you're looking at an x-ray at fracture conference, this is a skeletally mature or skeletally immature individual. You may not know the age. They may not have given you the information they said here and just describe these x-rays, but you can make the comment on, you see that the physes are still open. That's an important part of it. The next thing, which again, you may gloss over, but you need to put it into your brain as part of the algorithm, is look at the soft tissue. You might look at the soft tissue, it looks fine. So you just skipping up and soft tissues look fine. And you can comment, it's a good thing, and soft tissues look normal. But you might say, there's a foreign body, there's a mass, there's air in the soft tissue. This patient is of large body habitus based on the soft tissue envelope that you can see. Those are just all important things to incorporate. And notice we haven't even gotten into actually looking at the bones. But if you remember back to medical school, and you probably did a medicine rotation, they talked about the chest x-ray, you had to talk first, was it a good inspiratory effort? Can you see the cardiac silhouette? You went through in an algorithm of, look at the bones, look at the lung, look at the parenchyma, look at the heart, look at the diaphragm. And if you go through all of those things, you may not have to comment on it if it is normal and it's not bearing on the particular issue at hand. But if you have that algorithm in your head, you won't miss it when something is there and abnormal. You won't fixate on the intertroch fracture and miss the other huge mass on the other side of the pelvis that was a tumor. So you can't become that single tract mind and become tunnel vision. So we've gone through, describe the views that you have. Are they skeletal, immature? Is there soft tissue changes? And then for the knee, specifically when we're talking about the knee, we're looking at neutral alignment, varus alignment, valgus alignment, referring to the joint spaces, and it's always good to kind of describe, where the joint space is narrowed. Is it narrowed medially, laterally, bicompartmentally, femoral, tibially, patellofemoral? Is there lateral tilt? And again, this is even important for, sports stuff too. There may not be arthritis, but, is there lateral tilt? Is there lateral subluxation? Is the trochlea dysplastic? All of those little things. In the arthritic world, we're also discussing, osteophytes and subchondral cystic changes and sclerosis, because you may not worry about it now, but when you get out into practice, having the verbiage of severe arthritis and osteophytic changes are those silly buzzwords that somebody at the insurance company with a 3-ring binder checks a box to say, oh, they're approved for knee replacement. So it's important to have all that. Do they have retained hardware? Are there changes consistent with old removed hardware? Did they have an old, HTO? And then do they have a patella baja? Do they have a patella alta? So again, you're making all of these comments to explain to the viewer what they're seeing. On the hip, it's similar. So if we're looking at the hip x-ray, again, you've gone through describing the views and the soft tissue and, skeletal immature, but, is it a good AP? Is there pelvic tilt? What is the appearance of the visualized segments of the lower lumbar spine? Can you see degenerative disc disease? Can you see a scoliosis? Do they have acetabular dysplasia? Do they have a protrusio? If you do have a good AP, you might be able to comment, on what's the version. Is there a crossover sign? Is there a lot of offset, a little bit of offset? Do they have a valgus neck shaft angle, varus neck shaft angle? Are there changes in calcifications of the trochanter consistent with old trochanteric bursitis or gluteal tendinopathy? And then, joint spaces, normal joint space, mild, moderate, severe joint space narrowing, osteophyte, subchondral cystic changes. So those are all things that you want to use as those verbiage, as opposed to going, as a 76-year-old person, they have bad arthritis. That's what we get sometimes, and is they have a fracture of their hip. Okay, where and what kind? So if we're talking about hip fractures, and again, it's good to know your classifications, but again, describing. And this is a good one to kind of, keep in mind too. I mean, go back if you haven't listened to my other, lectures, like the Garden classification, the Powell's classification. If you're looking at femoral necks, you don't need to start with the classification. It's great if you can, but it's good to kind of go through and describe. They have a complete, incomplete fracture. It's displaced. It's non-displaced. It's vertical. This is the degree angle. And also intertroch, subtroch. Is it reverse obliquity? Is it subtrochanteric extension? describing all of those things. But again, you need more than one views because it may look aligned on the AP, and then notoriously, lo and behold, you get the lateral and there's 100% displacement. So having all of those views in front of you allows you to give an accurate description of what you're looking at. Now, let's talk about joints, briefly. So if you're talking about the wrist, you're talking about the tibia plateau, the tibial plafond. If you're talking about joint fractures, then you're describing, this is a fracture of, the distal radius. It is extra-articular, or is it intra-articular? And then describing the common findings. Is it transverse? Is it oblique? Is there a forearm fracture? Is there a spiral? Is it comminuted? Is there a butterfly fragment? Is it a skeletally immature patient? Is it a green stick fracture? Is it a torus fracture? So get in the habit of using all of those words. And if you're not used to it, you're not comfortable, get a bunch of x-rays and just practice describing them out loud. It sounds silly, but you can look at it and have an idea of what you think you see. But if you actually try to speak it or write it down, it really gives you an idea of where your brain is going. And it's going to help you if you kind of, make a little cheat sheet of what works well for you. What order of, sequence do you look at things? It's going to help you remember, I go through this algorithm every time. And again, you can kind of gloss over when you get a 70-year-old with a hip fracture that she's skeletally mature. You could skip over that. No one's going to say anything. But if you have that in your thought process, when you see the skeletally immature open physeal patient, you do make a comment on it. So that becomes really, really important. So it's a bunch of information. What I think I'll try to do is, on my to-do list, what I'll try to do is go through, a series of x-rays. I'll find some shoulder and some elbow and some wrist and some ankle and some, foot and knee and hip. And then at least, going through to show you one or two examples of, this is an x-ray and this is how I would describe it in fracture conference. And again, you might have some tendings that are like, it's 11 o'clock at night. They just like, send me the picture. Do I have to come in or not tonight? We're going to operate on it tomorrow or not? So, pick and choose wisely, but in the formal setting of fracture conference, making sure that you go through these algorithms to make sure that you can speak the language. And then, what you're talking about, you can paint a picture and it's going to help you understand what you're actually looking at. And then again, if you understand the classifications and the treatments, a lot of times how you describe the fracture is going to help you dictate what treatments, there may be, especially when it comes down to certain fractures and angulations of deformity, or millimeters of step off at the articular surface, based on the x-rays. That's going to really help you define whether or not you can treat this patient non-operatively or whether or not they should be treated operatively. So beginning of the year, I thought it was kind of a good one to just get started on and just give you some information and feedback that's going to help you at Fracture Conference. But, keep reading and keep listening. And if you haven't already, please subscribe. And if you have some new PGYs that aren't aware of the podcast, please refer them on so they can listen too. And I will speak to you next time. And in the meantime, stay safe. You've been listening to Total Knee Tips and Pearls. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.